And this is the fifth part of our series discussing implications of physiology in patients with tricuspid regurgitation-related right heart failure. And in this part, we are trying to illustrate open questions for the therapeutic journey ahead. We will touch upon challenges in patient assessment, the need for adjunctive treatment targets, and challenges in multivalvular disease. When assessing patients with tricuspid regurgitation, we usually deal with an elderly cohort and multiple comorbidities, variable anatomy, and heart failure phenotypes. In addition, patients tend to present with advanced right heart failure, and I hope formats like this really contribute to lower the threshold of suspicion for right heart failure in order to detect and possibly treat these patients earlier. However, until now, there are no universal criteria allowing adequate disease staging, and especially the lack of the definition of futility complicates optimal patient selection. It has been suggested that treatment effects can be optimized in mid-stage disease, but whether this should be defined by RV function, here assessed as TAPSE, or more complex tools like this scoring system here is currently unclear. In addition, traditional non-invasive markers assessing RV function are hampered by its low dependency, and so non-invasive methods to really quantify load-independent RV function bear the hope to better characterize patients and stage them properly. And this includes baseline function as well as possibly RV contractile reserve. Changing gears a little bit, I want to show you in the next few slides 3 common scenarios illustrating a common problem. And this you've seen this pressure tracing earlier here in a patient with severe tricuspid regurgitation, and treating this patient, not even a perfect result leads to a nice reduction of the V wave and overall reduction in mean RA pressure. And then there's a second scenario. This is not that uncommon, actually. This is a patient with a torrential TR, very severe TR. And yes, you see prominent V waves, but overall RA pressure levels are not that elevated. And when you treat the TR, a nice result, you see a reduction in the V wave, but the RA pressure levels didn't really change. But this is just because they were not that high to begin with. And then there's the third scenario, in patients with very elevated right atrial pressures, very severe ventricularization, that even after optimal treatment of the TR do not come down. And I think this illustrates the fact that we have to put our focus more on the upstream chambers and venous system to really be able to evaluate the effect of TR reduction on the trajectory of central venous pressures. And this is illustrated here in a very recent publication looking at right atrial strain in patients with TR that's treated medically. And you see here that patients with an impaired strain had independently worse prognosis. Much more difficult, but much more interesting is probably the assessment of venous tone and venous compliance, as this might potentially also serve as a therapeutic target. Here's another scenario of a patient that you're probably all familiar with. This is a patient presenting with multivalvular disease, severe tricuspid regurgitation, and moderate to severe MR. And here the question really is what to treat, when to treat, and how to treat. And we know that when we're treating mitral regurgitation, the presence of significant tricuspid regurgitation at baseline is prognostically unfavorable, as is the persistence of tricuspid regurgitation after mitral intervention, which is the case actually in the majority here in 2/3 of patients in this study. It has been suggested that a combined intervention might be beneficial. However, we will need prospective data to support the strategy. And the list of uncertainties and knowledge gap doesn't end here, but I will need to refer you to these excellent manuscripts here at the bottom right to take a deeper dive into remaining issues. Before I come to the conclusion and summarize, that we live in an exciting time, being able to learn about a lot of tricuspid interventions in right heart failure. We need to improve patient assessment, including disease staging and RV function assessment. We need to more holistically characterize the right heart circulatory system, including right atrium and the central venous system. And we need to establish strategies to manage patients with multivalvular heart disease. And with that, I thank you and see you soon.